Welcome to Med1 Pager. My name is Benjamin, and today I'm going to talk about thyroid cancer. So thyroid cancer is named referred to a malignant neoplasm arising from the thyroid gland and epithelium, and rarely it's going to come from the parafollicular cells, and it represents the most common endocrine malignancy. So thyroid cancer is quite interesting because most of the times when you have virus of the thyroid, it is actually not going to produce any hormones, unlike most other cancers of other glands. They produce hormones, and this cancer also affects all age groups from the young, the middle-aged to the older-aged individuals. So it is going to account for 90%, 95% of all endocrine tumors, and its incidence is rising globally, and this is probably due to the increased detection rate, so by the ultrasound. So before we reported less rates because of poor detection, but now the rates are going high. And then the age, it is most common between the age of 30 to 60 years old, and it has more female predominance, except the anaplastic carcinoma, which we shall look at, that comes in equally in all ages. Then geographical variation, there is a higher incidence in areas of iodine deficiency. That is where we have the follicular type, and also in areas that have had radiation exposure. We can think of like Nagasaki, areas like Chernobyl in Ukraine, where we had a radiation plant actually burst, and there was a radiation fallout. So we have risk factors for thyroid cancer, and that is going to include thyroid expression. This is a very strong risk factor, and it's linked commonly to the papillary type of thyroid cancer. For example, in the Chernobyl, if we have someone who has had prior head and neck irradiation, most commonly in children who are undergone irradiation for things like lymphoma, sometimes they end up developing a thyroid cancer later on. Then we have genetic factors and mutations, and also family history is going to be a very, very important thing when it comes here. The family history is going to cause an increased risk of developing this thyroid cancer. Iodine imbalance, whereby we have low iodine, and that is commonly going to lead to follicular carcinoma, because when you think about it, in places where people have low iodine, that TSH is going to be high. The thyroid stimulating hormone. The thyroid stimulating hormone acts on the thyroid gland. It leads to increased production of follicles. So it makes sense that these patients will develop a follicular carcinoma. Then pre-existing thyroid disease like people who have Hashimoto's thyroiditis, these people are going to have these people who have like Hashimoto's thyroiditis are going to have a hypothyroidism, and that hypothyroidism is going to cause a high TSH, and the high TSH is going to contribute to the formation of the carcinoma. Also, people who have had like lymphocytic thyroiditis are also at a high risk of developing carcinoma. Then we have age and sex, where it's common in the middle-aged females. Whenever it occurs in male and the elderly, most of the times you have a worse prognosis, and the elderly are most associated with poorly differentiated cancers. This is a very, very bad cancers. The cells are poorly differentiated. They don't look like any normal tissue in the body. Then we have environmental or lifestyle, where obese people, pollutants, and insulin resistance are also weakly associated to developing of this cancer. So when you go to the clinical presentation, people with thyroid cancer, most of the time it's going to come as a painless thyroid nodule. It's small, and it may be incidental. Maybe on examination, we find out that someone had a small node in the a nodule in the thyroid. But sometimes it can be a neck mass, and most of the time, so that's when you have had a goiter before, a multinodular goiter, and the goiter transforms into a carcinoma. And it's going to be associated with local effects like dysphagia, dyspnea, stridor, hoarseness, and rapid pain. And the rapid pain is commonly associated with the anaplastic carcinoma. And this is because of the invasiveness of cancers. They mostly invade the things around them. And behind, next to the thyroid gland, behind it, we have the esophagus, the trachea, we have the recurrent pharyngeal nerve, and that one is going to cause this hoarseness when it is infiltrated. When we infiltrate or have pressure on the trachea, it's going to cause this stridor. Then the spread, most of the time when we have a papillary carcinoma, is going to spread via the lymph nodes. So lymph nodes are going to common in papillary carcinomas. For sure, carcinomas, unfortunately, they are blood-borne, and you may have just metastasis. Someone presenting with metastasis to the bone, to the lung, and the liver. The medullary can metastasize by both ways. And then anaplastic is aggressive, but there is aggressive local and distant spread. Then when we look at the systemic or paraneoplastic syndrome, this means that we are having symptoms that are not actually related to any hormones or normal functioning of the thyroid gland. You have things like in the medullary carcinoma, it's associated with diarrhea and flushing. And this is not something that you actually can relate to being related to his particular gland. Then you have the main, it's associated with the main two. Then anaplastic carcinoma is associated with the cachexia, where we have severe weight loss, and the weight loss cannot actually be explained how. Then you have red flags, being male, being less than 20. If you're less than 20 and you get a thyroid cancer, that is a very bad thing, and it's a red flag. Being over 60 is also a red flag. Rapid growth, a hard and fixed mass is a bad thing. Coarseness, that shows the movement of the recurrent ligature. If the nodes are, if it's not positive, or there is enlargement of nodes, if there is prior radiation, it's also a red flag. And if there's a family history, it's also a red flag. So when we look at these thyroid cancers, we are going to look at how we can classify them. And the easiest way I found to classify them is depending on the cell of origin. So we have the follicles. Basically, the thyroid gland is made up of lobules. It's a lobulated gland. And these lobules, think of them as small rooms in a big house. And each lobule has cells within it. So you may find one lobule having around 20 to 40, 30, 40, 20, 10 to 20 follicles. And these follicles are lined by tuberoidal cells. So these follicles, in between the follicles, you have the parafollicular cells. And next to the follicle and parafollicular cells, we have the non-epithelial cells, and that is the lymphoid tissue. And this is where the lymphomas can start from, the metastatic lesions is born. So when you look at follicular epithelial cells, normally we have carcinomas arising from here, and they can be well differentiated or poorly differentiated. So if they are well differentiated, they'll give us the two types of carcinomas, that is the papillary and the follicular carcinomas. They're coming from the follicular epithelial cells, and you're going to look at them and how they differ. Then if there is poor differentiation, we shall have what we call the anaplastic carcinoma. So the anaplastic carcinoma is going to occur when we have poor differentiation. The follicular cells are increasing, but as they increase, they tend to not look like anything because of very bad changes in their DNA, or the DNA that goes for their structure. So examples of these thyroid cancers from follicular epithelial cells are going to be papillary follicular, hantho cell carcinoma, and the anaplastic carcinoma. In the parafollicular cells, you said these are the cells that are next to the follicles. They're in between the follicles. They're going to give a type of carcinoma. This is a neuroendocrine carcinoma, and it's called the medullary carcinoma, and it's associated with production of calcitonin, and we shall look at that also. Then you have the non-epithelial cells, where we can have a lymphoid, where we have a primary thyroid lymphoma, and then we can have metastases, and these metastases commonly come from like renal, and others. So the etiopathogenesis are most of the things that involve the information of cancer or in thyroid cancers are going to come from genetic mutations, and the genetic mutations can come from things like radiation and so on, as we have seen. So what happens in papillary carcinoma, that most commonly the pathway that's affected is the MAPK pathway, and the BRAF and RET, whereas the PTC genes are mostly involved, and these ones are going to occur because of radiation. Then in follicular type of carcinoma, the P13K and the AKT pathway is going to be involved, and within this pathway, the RAS, the PAX8, and the PPAR-gamma are going to be affected, and is associated with low iodine areas. Then the medullary is associated with the RET mutation, and this is a mutation that occurs in the MEN syndrome, MEN2, and they're associated with production of calcitonin. Then anaplastic carcinomas are going to occur when we have a TP53 mutation, beta-catenin mutation, and the TAT mutation, and these are going to cause the de-differentiation of the cells. So as cells are increasing in number, when we have hyperplasia, the TP53, the beta-catenin, the TAT are going to ensure that things move in an organized manner, and we have formation of actually the cells that we acquired too. That in anaplastic carcinoma, we have mutations there, and we end up with de-differentiated cells, and these de-differentiated cells are going to be poor, are going to give us a kind of high grade when you think about it, it's a high-grade carcinoma. So most of the times, actually, when you have a anaplastic carcinoma, it's already considered stage 4 cancer because it's poorly differentiated. Then we have hormonal influences, things like when you have increased thyroid stimulating hormone, because thyroid stimulating hormone needs to increase in the number of follicles, and when you have increased number of follicles, it means you're increasing hyperplasia. When we have cells rapidly increasing, there's room for error. That is where the cancer is going to arise from. And then you have estrogen. Estrogen also has some effects on increasing the activity of the thyroid gland, and that is possible to increase the hyperplasia in the gland or increased number of cells in the gland. So when we look at papillary thyroid carcinoma, this is a more common type of carcinoma that covers about 80% of individuals, and it occurs between 30 to 40 years and has a female predominancy, and it is specifically very key. Metastasis or spread through the lymphatic system, that is the papillary carcinoma. And this carcinoma is also the carcinoma that is associated with prior history of radiation. Sometimes you have the RET and PTC mutations as well as the BRAF. The BRAF is a very important mutation when it comes to the papillary carcinoma because they are BRAF antagonists or drugs that target that BRAF system, and these are some anti-targeted therapies that are used in the management of thyroid cancer. Then histologically, when you look at someone with a papillary carcinoma, we have things like the often anenuclei, which are clear and empty looking. We have nuclear grooves, nuclear inclusions, we have psammoma bodies. And whenever you see psammoma bodies, then we are talking about the papillary thyroid carcinoma. Then you have the variants. We have the classic variant, the follicular, the torsal, the diffuse carcinoma, and the microcarcinoma. And these are just variants of the papillary thyroid carcinoma. The prognosis is excellent, and the 10-year survival rate is actually greater than 95%. So most of the time, these people with papillary carcinoma will live to see 10 years post-surgery or after they have been diagnosed with the disease. Then the key phrase, or what we use to remember this, is that papillary carcinoma is associated with psammoma bodies, and it mostly is going to present as a painless node. It's a small node that is going to be in there. So we have the other papillary thyroid carcinoma variants, and these are going to include the follicular carcinoma, which basically is a papillary carcinoma but has a follicular texture. But when you look at the other things like the nuclei, they're going to look like the ones that are seen in papillary carcinoma. Then the prognosis is where most of the times put. Then you have the torsal variant, which is more aggressive and occurs in older individuals that has a higher recurrence rate. Then you have the diffuse sclerosing, which is young, multifocal, and most of the time you have nodomates. Then the columnar, which is rare and aggressive. The Hopner, which has apiconuclei and it's aggressive. Then the cribriform, which is associated with familial adenomatosis or polyposis, which is basically a syndrome where people have a lot of papillomas, polyps, adenomatous polyps. It's actually a good prognosis too. Then we have the follicular thyroid carcinoma, and this is also coming from the follicular iodine epithelial cells, and for it occurs in areas that have a low iodine uptake. So these people most of the time have a goiter involved, or you have a previous multinodular goiter involved. So it occurs within 40 to 60 years old and slightly older than the ones that get the papillary thyroid carcinoma. So most of the times probably have a history of a long-standing goiter that now starts to all of a sudden increase in size, and they start having these symptoms coming in. So the spread is mostly hematogenous, and it's going to spread to bones, to lungs, and to the liver. Histologically, it has a follicular texture with a capsule, and it may have or not have vascular invasion, and this is what distinguishes it from an adenoma, that it's capsular and may have vascular invasion. Then the variants, we have the hepatocellular carcinoma, which has oxyphilic cells that is even more aggressive and has a poor radioiodine uptake. The prognosis is good, but it's worse than papillary carcinoma and depends on the extent of invasion. So the key phrase to remember follicular cancer is that follicular is via the blood flow. Then we have the medullary thyroid carcinoma, and this one is associated with the MEN2A, MEN2 or MEN2B, and it's due to a mutation in the RET. And 75% of it sporadic, which means when people without these genes may actually get medullary thyroid carcinoma, and it going to originate from the parafollicular cells, which we say that cells that are neighboring the follicles. So they produce calcitonin in these cancers. So when you look at the histology, we have an amyloid stroma, which is of course derived from calcitonin, and nests of polygonal spindle shells. So the biomarker, you have elevated serum calcitonin and carcinogenic antigen, and the spread is both lymphatic and heterogeneous, and the prognosis is moderate, and it's better when we have the sporadic cases, not the ones that's treated with the men. So the key phrases like medullary is treated with men to A or to B, and calcitonin. So when you look at other tumors, we can have primary thyroid lymphoma, and usually it occurs in people who have had Hashimoto's thyroiditis, who now they present with the rapidly enlarging penias mass. And then metastatic tumors from the breast, kidney, or lung are rare. But we can have cells from these organs also being metastasizing to the thyroid. When you do investigations, the labs, we can do the TSS, which is usually normal, the thyroglobulin, which is going to be high in thyroglobulin is going to be high in the differentiated thyroid carcinomas, because the differentiated thyroid carcinomas are coming from the follicular cells, and the follicular cells, what they contain in the middle of them is thyroglobulin. So when you do a thyroglobulin test and you have increased follicular cells, the thyroglobulin is going to be high. Then calcitonin. Then for calcitonin, it's going to be all calcinogenic antigen is going to be common intermedullary thyroid carcinoma. Then when you do imaging on ultrasound, and that is the first line imaging you do, we can do radioiodine scan for the differentiated thyroid carcinomas, because these are derived from follicular cells, and follicular cells are the ones that trap iodine. So if you have a tumor here, it will blow up when we use radioiodine, and then we shall be able to tell. When we do CT and MRI, if we can do CT and MRI to stage and see if it's large or invasive. We can do a PET scan in iodine negative or aggressive tumors. Then we can do the cytology, which is the FNAC, and we grade the results of the FNAC based on the Bethesda classification, and we shall look at that one briefly. We can do a core biopsy if lymphoma, or if we have inconclusive results. Then the staging, we're going to use the TNM staging, and then the HSCC. We're going to grade the tumor using TNM and the HSCC 8th edition to stage the tumor, and we shall look at that. So the Bethesda thyroid cytology is going to come and with the categories and the risk of malignancy and the management. So when you have a Bethesda one, it is non-diagnostic, and normally we need to repeat this FNAC, because in FNAC we're just picking a small amount of cells and hoping those ones are the ones that will give us the clue to what's happening. So whenever it's non-diagnostic, we may need to repeat it. Then the Bethesda 2, if it is benign, when you do it and you confirm it's benign, and we may just need to do a clinical follow-up on that patient. Then Bethesda 3 is when we have something that is suspicious. You're suspecting something, and then you want to, what we shall do is that we want to repeat the FNAC and do a molecular test. Then Bethesda 4 is when you have a follicular neoplasm, or we are suspicious of one. And for it, most of the time we do a diagnostic lobectomy. So someone will go in for surgery, and when the lobe is removed, a frozen section can be done, or histology can be done to find out if they really have a neoplasm going on. And then Bethesda 5 is when it's suspicious for malignancy. And most of the times that we also do surgery, a lobectomy or a total thyroidectomy. Then if it's malignant, you want to do a total thyroidectomy, plus or minus neck dissection, depending on late node involvement. So when you look at the TNM classification, you have the T, the N, and the M. T for tumor, N for nodes, and M for metastasis. So the tumor is going to be spreading at it very according to its size. So we have a T1, T2, T3, and T4. And T1 is going to be a tumor less than 2 centimeters. T3 is when the tumor is greater than 2 centimeters but less than 4. T3 is when it's greater than 4 centimeters. And minimal extension, that is if it involves maybe the strap muscles. You can still say it is T3. But when we have invasion beyond the strap muscles, then we have a T4. That is, if it goes to the strap muscles, the trachea, the esophagus, the paravertebral, carotid, and mediastinum, things around there, that is a T4. Then the nodes, we have the N node, N1A, N1B. And N node is when you have no nodes. N1A is when you have the central group of lymph nodes affected. That is level 6 of the neck lymph nodes. And I'm going to do a review of the neck lymph nodes in a few. Then N1B is when you have the lateral lymph nodes. That's level 3. Level 2 to 4, level 2 to 5, sorry, or mediastinal lymph nodes, and that is level 7. Then metastasis, M1, M node is when you have none, and M1 is when you have distant metastasis. So when you do a staging, we shall categorize our patients between patients less than 55 and patients greater than 55. So someone with less than 55, we only have 2 stages. That is stage 1 and stage 2. Stage 1 is when you have NET and no NET or nodes. You have nodes, you have a tumor, but no metastasis. That's stage 1. And when you have metastasis, that goes to stage 2. That is for patients with less than 55 years. And if you're greater than 55 years, stage 1 is when you have a tumor less than 2 centimeters, no mets, no nodes. Stage 2 is when you have a tumor greater than 2 centimeters, less than 4 centimeters, no mets, no nodes. Stage 2 is when you have a tumor greater than 3 centimeters and greater than 4 centimeters with minimal invasion, that is not going beyond the strap muscles, but no nodes. And then, or if you have a tumor size from T1 to T3, that is only the central group of lymph nodes affected. So once the central group of lymph nodes is skipped, then we go to stage 4. Stage 4 cancer. And stage 4 has stage 4A, stage 4B, stage 4C. So when you look at just remind you about the lymph nodes of the neck, we have the level 1 lymph nodes, that is submental, the level 2 lymph nodes, level 2 lymph nodes over here, then you have level 3, and the landmark for this is the sternocleidomastoid. So we need various types of sternocleidomastoid in 2/3. The upper third is level 2, the middle third is level 3, and then the lower third is level 4. Then the lateral lymph nodes, that is lateral to the sternocleidomastoid, or on the other side, that is level 5. And then level 6 is going to be right here, and then level 7 is going to be the mediastinal lymph nodes. So the management of the thyroid cancer is going to depend on very differentiated thyroid cancers, medullary, and anaplastic. So when you have differentiated thyroid cancers, most of the time you do surgery, and it's going to be a lobectomy, which can be a total lobectomy, or it can be a total or a total neck, total thyroidectomy. It can be lobectomy. And then we shall always follow this with radioiodine to avoid any possible metastatic tissue. We want to give radioiodine, which can be radioiodine 123. That's for diagnosis, and then the heavier radioiodine can be used to ablate the tissue. Then we can do TSH suppression, and after TSH suppression, we may measure the thyroglobulin, or we can do the ultrasound to follow up. But thyroglobulin is better used because these diffuse thyroid cancers are going to contain thyroglobulin within them. So if you have clearly destroyed all the tissue with your iodine surgery, then thyroglobulin should go low. Then we can do the medullary. When it's a medullary thyroid carcinoma, normally we do a thyroidectomy, lobectomy, and neck dissection. And for it, we shall monitor with calcitonin and carcinogenic antigen. And then we may test for the rate, because the rate is associated with higher recurrence rates and a poorer prognosis. Then the anaplastic carcinoma, if the surgery is possible, if things have not yet invaded a lot of the structures there, do surgery and then you can give chemo, but most of the time you just put it by palliative. And then anaplastic also occurs in the older individuals. Then the principal is going to be surgery, which may be primary, we may have adjunct based on the type, the risk, and in the prognosis. So when you look at the prognosis of cancers, the differentiated thyroid carcinomas have a better prognosis, followed by the medullary, and the anaplastic carcinoma has the poorest prognosis. So we have come to the end of this video, and we have covered a regarding thyroid cancer. I hope you were able to understand a lot, and